I have a question for both Dr. Zhong and Dr. Abe. So, in the U.S., we do screening and screening for an endoscopy for people with GIM. We always take biopsies. We take biopsy, follow our protocol. But in Japan and Korea, I understand that you do very good exam. Do you take a lot of biopsies, and what's your protocol of biopsy?
For intestinal metaplasia?
For screening for gastric cancer, do you take biopsy or only by just looking without taking biopsies?
Only taking biopsies at the tumor site.
So you do take biopsy from the tumor site. My impression previously, if you take biopsies, they're going to create some fibrosis for downstream with some difficulty downstream to when you perform ESD because it's fibrotic. Is that a concern for you?
Yeah, no problem for the biopsy site during ESD because biopsy can take only a superficial area. It take including mucosa and a very small portion of some mucosa, so there's no problem.
Okay.
Yes, similarly in Japan, we are more likely to diagnose intestinal metaplasia optically using the virtual chromoendoscopy, such as NVI. Using NVI magnification, we can see the white-blue crest, which indicates intestinal metaplasia optically. So we don't usually take biopsy. Also, the preoperative biopsy doesn't matter to do ESD thereafter. That's no problem.
Yeah, I think the difference is that they don't do aggressive biopsies, right? I mean, I think that the training here in the U.S. is if you're worried about a malignancy, in the past, it's like, oh, take a bunch of biopsies, make sure you don't miss the diagnosis. If you go to Asia and you watch them biopsy, they're very delicate about their biopsy. So they don't take jumbo biopsies and do like 8 biopsies of the lesion. So if you do biopsies carefully, you don't cause the fibrosis and it doesn't impact the ability to do ESD, correct?
I agree with you. Please don't do the prior EMR attempt or top tattoo on the lesion.
So I guess you don't really use that Sydney protocol to take biopsy in Japan or Korea. Is that correct? Yeah. We take biopsy using the Sydney protocol. We just take biopsy from the body 2 bites in the sera and antrum 2 bites. You don't use that protocol in Japan or Korea.
In our practice, we don't follow the this protocol. We just do take a biopsy on any suspicious lesion or malignancy.
What about to diagnose H. pylori?
H. pylori infection can be examined by non-invasive method, such as a urease breast test. This is a current Japanese standard. Also, we can check before endoscopic examination.
For the newcomer, you can take biopsies for the analysis of antibiotic resistance from environment body, because we have data that sometimes some patient has multiple strain Helicobacter pylori antibiotic resistant status. So take at least 2 sites and using biopsy specimen for the diagnosis of the status of H. pylori. And in the past, we taught from textbook should take biopsy at least 4 from the tumor, suspicious of tumor. Yeah. So nowadays, we can take just 1 biopsy at the tumor site, and then took large particle removal using EMR or ESD. And so far, we have so many patients with intestinal metaplasia. So just to see through the white light and the MBI system. And then for the very suspicious lesion, you can take biopsy. But 2 or 3 decades after, Japan and Korea may follow your principle for the young endoscopist.
A comment and a question. I guess a comment is in the U.S. where there isn't as much gastric cancer, probably the biopsies are partly to identify that group that then we then survey, whereas it sounds like in Japan and Korea, really everyone's already in the surveillance protocol just by being in the country. So that, I think that may be where there's some difference. And then a question for Dr. Raquelame. A lot of us use antiparietal cell antibodies and intrinsic factor antibodies for sort of a classic patient with pernicious anemia and autoimmune gastritis. You imply that these antibodies, and we've seen in our practice a little bit with people with really extensive H. pylori, that antibodies become positive, and not really autoimmune, but maybe a marker more of just injury to the stomach. Is your team kind of looking at and what are your thoughts on looking at quantitative levels of those antibodies as screening tests?
Oh, yeah. You are talking about autoimmune gastritis in terms of...
Well, just using the antiparietal cell antibodies as a marker for everyone, even with H. pylori-related risk factors for gastric cancer.
Oh, yes. We don't use widely the autoantibodies. Is just the starting point. What we use for the general population is aberrant endoscopy. We don't use at the moment the serum strategy. So it's not common for us in Chile to use serology. What we use is aberrant endoscopy and biopsies. We follow the same training program that they have already developed in Japan and Korea, but we started taking biopsies in 2014. But our long tradition is Japanese tradition. We have a strong connection and a strong bond with the Japanese Institute, and people coming from Japan for decades training us. What is slightly different is we started 8 years ago to take biopsies, to have this Sydney protocol, to have a clear idea how to deal with the GIM. But I completely agree with you. I'm also using the EGGIM, the Portuguese protocol, to establish the surface, the extension of gastrointestinal metaplasia, and the correlation with the Olga and Olgim is extremely accurate. So I think it's not a problem to follow a strategy without biopsies if you're well trained. And also I have a question for the panel, because what we learn is if you have these regular venules and you have the round crypts, and you don't have any Blue-Crest sign or other indices of gastric intestinal metaplasia, usually these patients are Olga 0, and I want to ask, what do you do with this? Because if you have, for example, in Korea, every 2 years follow-up, what do you find? For us, it's nothing. So after 10 years, those patients, no problem, no progression to other stages of Olga or Olgim. So I want to ask you.
Yeah, actually, I participate the Chilean gastroscopy screening program in 2019 in La Serena area.
Yes.
Yeah, so that during 7 days, I took many endoscopy and teach and doing by myself. Interestingly, the H. pylori prevalence was very low, and there is nothing atrophy and metaplasia. So those conditions, if you can see the abnormality, either atrophy or metaplasia, can take biopsy. But in Korea, still for 50s and 60s, everybody has abnormal area. So we cannot take biopsy for those patients. So we should pass for the mild to moderate area, but the severe focus we can take biopsy. Yeah, so there is a difference between the Asian and the Western countries.
This is maybe, in a way, a follow-up. Another outstanding session. And we see the contrast between Chile, where there is an established program, you're talking about endoscopic capacity, and then the tradition in Japan and Korea for frequent screening on everybody. So from the previous session, I'm wondering what the perspective is from Japan and Korea. Can you find a group of patients who are low risk, who you will not bring back at 2 years, or you think you will continue with frequent 1, 2, or 3 year follow-up for everybody?
Okay, a really tough question, but I personally think the risk stratification is very important. And in my experience, I have no experience of detecting the early gastric cancer on the low risk group. So I think that we can pass the examination for low risk group. And on the other hand, the high risk group, we need to continue the surveillance endoscopy and screening endoscopy, and even after 5-year follow-up, so that we can stratify the risk according to the some clinical result and basic result.
Yeah. And for us, it's more or less the same, but we develop these strategies. We have the Chilean guidelines, and for Olga 0, no follow-up. Only if you have Olga 0 and HP persistent. If you are Olga 1 or 2, you can follow every 3 years. And at the moment, for Olga 3 and 4 is annual follow-up. But what we discover is you have this, it's not necessary to have this strict follow-up. Probably we are closer to move through 2 to 3 years. Probably 3 years is good enough for us. But as you mentioned before, the problem for us is the limited resources in terms of the endoscopic capacity. If they mentioned 15 million endoscopies in that period, it's not impossible for us to do it because we are at the moment have waiting lists for symptomatic patients. It's impossible to offer this endoscopic capacity in the near future. Probably after 5 or 10 years, we need to create new endoscopic units to have more gastroenterologists or surgeons performing endoscopy with high quality. So it's a big effort to do it.
A wonderful session, so thank you. This relates to the use of AI for the detection of intestinal metaplasia or premalignant conditions. In the US setting, probably the value of a screening program may be equally balanced between determining those who need surveillance and the detection of early gastric cancer. And in fact, the value may be more in the former. So I'm interested in the possibilities for AI for the detection of premalignant lesions.
Thank you for your question. So in Japan, as Dr. Abe said, we diagnose intestinal metaplasia optically. Almost all Japanese endoscopists can diagnose intestinal metaplasia. But so before, in USA, I heard that there is no screening program for gastric cancer. So before to receive endoscopy, I feel we will go to build AI to detect and suggest intestinal metaplasia. We are planning to do research and development to detect and suggest intestinal metaplasia.
Even more with AI, we should do proper preparation before endoscopy and can take a very clear mucosa of stomach and others. And then we should use the adequate amount of air, less or large, because it can be changed the shape. So it is totally depends on the endoscopist, not depends on the AI. So AI is next or additional tool other than human. So human skill is more important. So when I doing endoscopy in La Serena, my observation was they are very speedy from mouth to stomach, nothing to see. So they are very curious for me. I do endoscopy from mouth to sometimes to reach the proximal esophagus, it takes 20 seconds because very careful see careful observe the throat and hypopharynx, and then smoother pass. But they don't see the proximal part of the human body. So those things is very important. And then we should emphasize the biopsy issue. And then next step is AI issue.
Yes, one additional comment. I totally agree with you. So the AI is more likely to use for the IM detection. But only the challenge is the AI is originally developed by the high quality image. So in order to adapt the clinical settings, the AI should include the general quality of the image during the 3 minutes EGD procedure. That is the next challenge, I think.
Thank you for the excellent and informative presentations. I am interested in autoimmune gastritis, and as I understand, the diagnosis of autoimmune gastritis is still controversial. I would like to know what is the definition of autoimmune gastritis in Korea and Japan, and to ask you if you have any data suggesting that autoimmune gastritis is increasing over time. I believe that autoimmune gastritis is the risk factor associated with the increase that we are seeing in gastric cancer in young individuals, particularly women. Thank you.
Thank you so much for the question. In Japan, so maybe the incidence of autoimmune gastritis are increasing, but the incidence are still very low. In our clinical practice, we don't usually check the autoimmune gastritis by the blood test. But normally, the gastric cancer develops from the just atrophic gastritis owing to the H. pylori infection. So but I think the gastric neuroendocrine tumor is more likely to be detected rather than gastric cancer in my practice.
For the autoimmune gastritis, usually, maybe always overlooked because the H. pylori. So in the future, the prevalence of autoimmune gastritis and atrophy may be increased. So we should cautious for the interpretation. But so far we cannot because very much predominantly H. pylori is concealed.
I want to add that when we start with our program before Sydney protocol, we have 0% of autoimmune gastritis. When we started taking biopsies systematically after 40 years old, we had 1.7%. So if you take biopsies, you will find this atrophy in the corpus and the increased number of proliferation of the endochromophil cells. So I think it's a need for classification related to autoimmune gastritis, because what we use is Olga system, which is not designed for autoimmune gastritis. We need a very standard classification to have a common idea in all countries. Other thing that is important is in the discovery cohort we use antibiotic cells, and 30% of subjects have positive antibiotic cells. So if you use serological markers, you will have an overestimation of the autoimmune gastritis, because after the biopsies you will not find autoimmune gastritis. Which is specific is the anti-intrinsic factor is specific, but it's less than 1%. So I think this is going to be very important in the next 5 years to establish which is the prevalence of autoimmune gastritis in all our countries. And I agree with you that if the infectious disease and the H. pylori is going down, probably the autoimmune gastritis is going to be up, particularly in females after 40 years old, thyroid disease, and some association related to mucocutaneous diseases like vitiligo or other autoimmune skin diseases.
Okay, fantastic. Can we give a round of applause to the moderator and the speakers? Thank you.